Christine. I'm the program manager for the Trauma and Burn Service. Been with Trauma for, gosh, about 14 years now. And I'm going to spend some time talking to you today about massive blood transfusion, the massive blood transfusion protocol. I have, through my 14 years, I've had a lot of opportunity to work with the blood bank. 14 years ago, we didn't have massive blood transfusion protocol. You know, I got to know them quite then. We've had a lot of transition in the blood bank, and I will share with you as we get started. Working with blood bank is actually an absolute joy. They have become one of the departments that really has partnered with us well, both on the medical and the nursing side, to help make us successful with massive blood transfusion. So just a little bit of history as we get started. MBTP, it all kind of started with trauma. And it really started in the military. When you think about how do people in the military get injured, it's usually a penetrating trauma. Penetrating trauma means a lot of blood loss. A lot of blood loss means you need to replace that blood. And the best thing to replace blood with is blood. When you lose blood, you get shot, you get stabbed, you are losing whole blood. Our goal is to give you back whole blood because you need all the different components to do what your body needs to do to heal. So you have a penetrating injury, you need volume to replace the volume that you've lost, which we can get through our blood products. You need hemoglobin, which carries your oxygen. In order for us to have oxygen carrying capacity, get oxygen to the tissues, we have to replace that. And we have to replace your platelets and your clotting factor. We do that through our yellow products, our platelets, our cryo, and our plasma. And so right now, the way we do massive blood transfusions is it's all a component therapy.
If you want to walk, I can't hear you.
Oh, okay, sorry. You know me. No, I won't walk. I'll be good. It's component therapy. And so the goal of what we're trying to do is put together all those components to make it look like we're giving whole blood to our patients. So our replacement needs to be whole blood. And we'll talk a little bit about why we don't give or where we're going with whole blood in a little bit. Now, the reason for this is, 30 plus years ago when I first started in the ICU, we were very red cell focused. A patient needed volume, we really focused on giving red blood cells. Well, if I just give a whole lot of red cells, I'm giving a lot of hemoglobin, so I'm carrying oxygen through my tissues, which is great, but I'm diluting out all my clotting factor. And so this increases our hemorrhagic mortality. And if you give a lot of red cells without giving any yellow, you'll notice your patient gets oozy. Around the IV starts to get a little leaky. You do a lab draw and they won't stop bleeding because we've diluted out all their clotting factor. And so this is why we're going to start giving FFP pretty quick because we don't want to dilute out all that hemoglobin because we need it for tissue hypoxia. But if I just give yellow products, now I don't have oxygenation, and so I'm not doing well. So if you've ever really heard me talk about massive blood transfusion, you'll understand what this means. If you have a hot dog, it has to have equal parts of mustard and ketchup for it to taste right. If I have too much mustard, I can't taste the ketchup. And if I have too much ketchup, I can't taste the mustard. That's exactly what we're going to do here with massive blood transfusion. I want equal parts of yellow product to red product. And if I have equal parts, then my body's going to respond well. I'm going to have enough oxygen carrying capacity with my hemoglobin to get oxygen to my tissues. And I'm going to replace my clotting factors, my platelets, so I don't become coagulopathic, and everything works well. It's a nice, happy hot dog. So if you ever launch massive blood transfusion, I want you to think hot dog, and that's where we're trying to get to. So does this work? There's early studies out there that were done in the military because they had the most volume. And they looked at one-to-one transfusion, meaning for every unit of red cells, we gave a unit of plasma. And it's pretty impressive what they saw here. So in this first one, for every 1 unit of plasma, they were giving 8 units of packed cells. The overall mortality was 65%, and our hemorrhagic mortality was 92.5% because our patients were coagulopathic. We were diluting out all of the mustard. So then they looked at 1 unit of red cells to 2.5 units of packed red blood cells. Overall mortality more than cut in half. And our hemorrhagic mortality went down, but we're still overpowering the yellow. And so then they looked at really kind of a one-to-one, and look at what it did to overall mortality. Brought it down to 19%. And now our patients do not have a hemorrhagic mortality. They're able to clot as well as oxygenate. So that was kind of that early study done in 2007. And there's been several things that we've looked at since then. That just kind of got us started. Now I will say even today, it's been 25 years almost, we still don't have a universal definition of massive blood transfusion protocol. What we do know, massive blood transfusion protocol is activated anytime you have clinical massive hemorrhage that's hard to control. So you have a patient basically bleeding out in front of you. Pretty easy to identify. You have ongoing blood loss of greater than 150 mils per minute. Well, to me, that's the same thing as massive hemorrhage if you're losing that much blood. Or you have a loss of more than half of the estimated blood volume in 2 hours. This one's a little bit harder to measure, but it kind of says the same thing, clinical hemorrhage, that you should be able to identify. So our goal now, we've identified that this patient needs massive blood transfusion. They're losing a lot of blood, whether internally or externally, and we need to replace that blood. Well, what, about a year and a half ago now, we were able to get rid of our level 1 rapid infuser, and we purchased the Belmont. How many of you have used or at least touched the Belmont? Okay, good number of you. How many of you are really comfortable with the Belmont? Okay, 1, 2, maybe of you. Our goal is to get more people comfortable. This is one of my favorite pieces of equipment. And I will tell you, in my 14 years as the manager of the trauma program, I have two of my biggest accomplishments in this job. One is getting a blood refrigerator down in the code room. It only took me 10 years to do it. Why rush? And it was getting this Belmont. And the reason I love this Belmont is because it will allow you to bolus a unit of red cells or a unit of plasma. And it gets it in very quickly. It can run as fast as 750 mils per minute if you have the right size IV. For most of our young kids who have smaller IVs or an IO, it runs about 80 mils per minute, not 80 mils per hour, but 80 mils per minute. It does so while it also cracks the pressure of the line. So not only is it giving fluid fast, it's protecting your IV. It will not let it run more than 300 units of pressure. And if it does, it drops the rate. So we're giving it safely through a peripheral. We're giving it fast, and you don't have to just stand and push. And we're giving it warm. And warm is going to help your patients clot. Cold can't clot, and this is going to be able to help us. It's actually very intuitive to use. The problem is when you use it, you're usually a little stressed. And if you decided to use it just on the general patient when you weren't stressed out, you would actually notice it's pretty easy to put together and it's pretty intuitive. So for those of you who have a Belmont in your unit, this is one of those pieces of equipment, whenever you have a minute of downtime, it's a great piece of equipment to play with. Because once you get it down, it's actually really easy and quick to set up. Who does? She said labor and delivery nurses can use this thing like it's an everyday thing. And that's exactly what we want to get to. Anytime you need to give rapid volume, even if it's just a bolus, this is a great way to use it. It doesn't have to just be for massive blood transfusion. The only way you're going to get good at it is use it. And any child who needs a IV push, a rapid infusion, probably needs to have it warm. And so this will be your way to do that. And warm kids are going to have better pH, they're going to clot better, not just for trauma, but for everything we use. So that was my little rabbit hole, which we'll get back to. So let's go back to massive blood transfusion usage. So when we decided that the hospital needed an MBTP protocol, it was because the American College of Surgeons Committee of Trauma said that all hospitals had to have one.
So this was back in 2008, I think, and so I, jaunted up to the blood bank and I'm like, we need an MBTP protocol. And they said, why? I said, because the American College said so. And they weren't real excited about doing it, so my naivete, I just wrote one. And that freaked the blood bank out, and then 2 years later, we were all worked together and we had a massive blood transfusion protocol. So we've had one since probably about 2009, 2010. Now, the interesting thing is trauma really pushed this envelope, but we're not the primary users. The CICU actually uses it more than anybody in the hospital, which makes sense. You have all those kids that are, need rapid deployment ECMO, and there's a whole lot of blood going on with that. So we see it a lot there. The OR will use it for unplanned bleeding. And we've seen it a lot in the PICU, not just for trauma patients, but for HEMONC patients and for kids with things like GI bleed. And so it's not just a tool for trauma, it really is something that that we need to use for a lot of patients. So let's say you have a patient, whether it's trauma or not, but you recognize massive bleeding, and you were told we need to activate MBTP. Very easy. We have a hotline in the blood bank. It's 5656. And if you don't know what that number is, anybody in here have the trauma app on their phone? How many of you have the trauma app? Okay. If you don't have the trauma app, I highly suggest you get it. It's called CN Trauma, and it's available at your app store. Now, when you register, you'll have to register. Use your email. Please use your hospital email. Make my life easier. You will not get access to the app right away. I physically have to go in and approve it. And the reason I have to approve it is it has a lot of phone numbers in there, like mine, that I don't want, the general public to have. And so we've tried to keep it an internal app. But within that app, there's a folder called Labs and Blood. Go to Labs and Blood, MBTP. You will have all the information at your fingertips on your phone that I'm sharing with you today. So you're going to call 5656. You're going to tell the blood bank that you are calling to activate massive blood transfusion. If it is for an ECMO prime, let them know. They will ask you what the name, MRN, weight, age, and gender of the patient is, and where are you? Are you in the code room? Are you in the PICU? Are you in the CICU? Are you in the OR? Where are you? Because they're going to have to check blood out for you. And they will ask you for a physician contact number. So they have a physician, they can make sure that signs that order and does the paperwork. Now, there is a cheat sheet that goes with massive blood transfusion. And again, it's on that app if you don't physically have it in front of you. Basically, it says on that cheat sheet, give administration reminders, talks about filters, it talks about just PAC cells and FFP can be given on the Belmont, the rapid infuser, or the hotline. You cannot give platelets or cryo because you can't warm platelets with cryo, and also the platelets would get broken going through that Belmont the way it pushes fluids in, so it won't work. But those can be given IV push. I highly recommend if you are in a situation where you have to activate massive blood transfusion that you identify the leader of massive blood transfusion. That can be a charge nurse, that could be the crisis nurse, somebody who is going to just kind of keep track of everything. They're going to make sure that we're following the guideline, that we're getting labs when we need to. They're going to pick up the paperwork. They'll send a transporter to pick up the blood. They'll assist with blood verification. They're ones that will call the blood bank to tell them that we're done with massive blood transfusion. Or if you're in the code room or the OR, you might call the blood bank to say, hey, we're moving to the ICU, hey, we're moving to the OR, and to change location so they know where the patient is. But it's just that one person who is really watching the administrative end of massive blood transfusion. Now, paperwork. There's refrigerators in the CICU and the code room in the emergency department. If you pull blood from those blood or platelets, blood or plasma from the refrigerator, there's paper on there, and you're gonna need to get an MD signature on each piece of paper that goes, or on the piece of paper that goes with each of those units. And it's basically a release page. And then if we are sending for blood, whoever the transporter is we need to send them with a blood pickup request form. And all that is in the massive blood transfusion packet. Now, you will see on the massive blood transfusion packet, pack A, B, and C, and that's really how we're going to give volume. Now, this is changing a bit because the ER now has plasma in the refrigerator. Pack A for the inpatient areas is just red cells. Pack A for the emergency department is red cells and plasma. That way we can start with a balanced resuscitation. So pack A, we're going to start giving that blood. If you're on the inpatient unit, you'll get the red cells. It's going to increase your oxygenation. Again, if you're downstairs in the emergency department, you get the red cells to increase oxygenation and the plasma to help with that coagulopathy. We're going to activate, we have an active type and cross, that's great. A lot of these kids are not going to have an active type and cross, and one of our main priorities when we activate massive blood transfusion is to get a type and cross, because the quicker we can get type-specific blood, the safer that is for our patients. Pack B is now going to be packed red cells so we can continue the regeneration of hemoglobin. And this is now going to have plasma that goes with it, which will give you help us restore our fibrinogen and give us volume, and then platelets will be in Pack B. Pack B will come up with a cooler that your transporter will bring to you. And once Pack B has been released from the blood bank, they will start getting Pack C ready. Pack C is going to be more red cells. Again, that oxygenation is important. It'll be FFP, the volume, and fibrinogen. And then instead of platelets, you'll have cryo. And that's really the big difference. Now, once you've given that Pack C or that second cooler full, then if you need a third cooler, you'll go back to B. And they'll keep going back and forth from B and C until we discontinue massive blood transfusion. If we're giving everything they give us in those coolers, we will have a balanced resuscitation, meaning the ketchup and the mustard will be equal. One of the questions I get a lot is you get the cooler and you're like, what do I start with? Do I give all the red cells and then all the yellow cells? Do I start with the yellow cells and go with the red cells? I always tell people, when we used to have the level 1, I would say just alternate back and forth. But now we have the Belmont, and I'm going to show you a video here in a little bit. The Belmont's the best thing in the world because you can give yellow and red at the same time. And I know, don't get all twittered because, well, how will I know if I have a reaction, which one it'll be? This is massive blood transfusion. We don't care. If you have a reaction, you have a reaction, and we're not going to try to point which one it gave it to you. And we have very few reactions, just FYI. So if we can give plasma and blood at the same time through that Belmont, you go. And if you have enough access, give the red cells and the plasma on the Belmont, and then you take those platelets in a syringe in the other IV and start pushing those puppies in. So now we're giving all three at the same time. So don't worry about what you give first. Let's try to get as much in as fast as we can. Now these labs, if we don't have an active type and cross, we are going to start with O negative red cells and A or AB positive, or A or AB plasma. That's the, for plasma, that is the universal donor. With massive blood transfusion, you're going to want to send a CBC, a PT-PTT, a fibrinogen level, chemistries, and do a blood gas. In addition, we'll need a type and cross. If they are an acute patient and they don't have any type and cross in our system, then you need to send 2 type and cross samples. One to get the initial and the second to back it up, and it's kind of that second check. This is not my rule. This is not blood bank's rule. This is a regulatory rule. Now, how quickly should I get that second type and cross? You can get it within a minute. Matter of fact, blood bank has told me that if we draw labs, as long as you send the type and cross at the beginning, in that one draw, and then maybe a later syringe from that same blood draw, you can send them pretty much at the same time as long as they're a little farther apart, 30 seconds. We've even set up the massive blood transfusion order set that you can order both of these type and cross at the same time. So they have a little bit different name, because if you have the same name, they would cross each other out. Now, I've had a lot of people also tell me, okay, Jen, I've been in a massive blood transfusion protocol, and I know we're supposed to give, you know, for every unit of packed cells, a unit of platelets and or plasma, and then the platelets and the cryo, but the physicians now start to deviate. Is it okay that they started to deviate? And the answer to that is yes. Because if we have labs come back, whether it's on your EPOC or the chemistries you sent, the CBC, they may start altering depending on the clinical need of the patient. So you may find that our hemoglobin is sitting at 14, but we are still actively having some coagulopathy issues. So we may just keep giving plasma at that point. Your INR may be fine, but your hemoglobin's still 7. So we may keep going with red cells. So it's okay for them to make clinical decisions. We stop massive blood transfusion when the bleeding stops. What we have noticed since we have converted to the Belmont is we tend to over-transfuse now. In the past, we used to under-transfuse. Now we just get going with that Belmont. We're having so much fun, and that blood's just going in, and we just keep it going. And all of a sudden, you look up, and your tachycardia has resolved, and your blood pressure's back up to normal. That's when we need, somebody in the room needs to point out that, hey, look where we're at. It doesn't look like I'm massively hemorrhaging anymore. Vital signs have been restored. Do you want us to back off this blood and these blood products? And the answer to that is almost always yes. But what I found is a lot of times your physician colleagues are busy paying attention to something else, and they don't realize what you're still giving on that machine. So if you're the one at that machine, you're a good person to really be that partner with your medical physician to make this determination. If you, by PICU, SICU, ED, if you're going straight to the OR with a patient on massive blood transfusion, please make sure you call the blood bank to know that they're on their way to the operating room. Now, nurses at the bedside, what is your job during massive blood transfusion? Well, access, and that can always be a challenge, especially if you have somebody who's hypovolemic. They're not always easy to get. We have to verify all the blood components. And I'm going to be very honest with you, and blood bank knows this, so I'm not like telling secrets about myself. There are times where, you know, you have to do the 2-check with blood. I am spiking it, and we are checking it as it starts to hang because we are trying to get that blood in that patient as fast as we can. As a bedside nurse, we need to make sure our labs are sent. We're usually watching that infusion. We need to be in charge of documenting how much of that volume is going in. And it's really important that we know how many units of red cells, how many units of plasma, how many units of platelets, and if possible, let me know in milliliters how much you've given. And then most of these are not going to be through bridge. A lot of times with massive blood transfusion, bridge kind of goes out the window. And so we're going to have to retain those used bags and send them back to blood bank. We're going to document the start time of MBTP, the amount of volume we've given each hour, and what product, and what time MBTP stops. And those are kind of critical documentation pieces. Now, life is getting really excited with blood. I told you I had 2 big accomplishments, the refrigerator and the Belmont. The next big accomplishment we hope to see here at Children's is whole blood. This is being done in pediatrics. There's several hospitals who have started giving whole blood to kids. It is safe. A couple of things we do watch when giving whole blood is potassium level. And we also have to acknowledge that the platelets in whole blood often are not great. So even when you're giving whole blood, sometimes you may need additional platelet infusions. Now, we have not started giving whole blood because we have decided as a hospital to be part of a multi-center trial. And so as part of that multi-center trial, we were probably about 6 to 9 months away from starting whole blood. So be paying attention. You guys will all be hearing from the trauma service and from blood bank as we get ready to roll this out. It's really quite an exciting time. Not only will it look at whole blood and how that affects our outcomes of our patients, it'll also be looking at the use of TXA, which is TXA is a medication that we give in order to basically help the strength of platelets so they don't lyse early. And so that'll be part of the study also. So a lot of really cool things that we'll get to be a part of. Questions so far? And then I'll show a video of the Belmont.
There are several indications to use the Belmont. First and foremost, anytime you need to give a lot of fluid or blood products fast. Other indications, massive trauma, massive blood transfusion protocol, or sepsis. The Belmont Rapid Infuser can be located in the emergency department, the operating room, the PICU, and the SICU. In the emergency department, there is a Belmont in both code rooms. Always start by making sure the Belmont is plugged into the wall outlet and making sure that the electrical cord is attached to the Belmont. The cord can come loose from the machine with movement. If the machine won't turn on for you, make sure the cord is connected to the machine. The power switch is on the back of the machine. Remember to make sure that the machine is plugged into the wall and that the cord is attached snugly to the back of the machine. Once the Belmont turns on, there are instructions on how to put the tubing in as a reference. The company that makes the Belmont suggests to start with the heating element, but we have found it easier to start with the interlock block. You will need to gather the Belmont disposable tubing and the Belmont extension tubing. The Belmont tubing alone is quite short and you will need to attach the extension tubing to the end of it. Start by attaching the Belmont extension tubing to the end of the main Belmont tubing. After attaching the extension tubing to the end of the main Belmont tubing, you are ready to place the tubing into the Belmont system. Using the Belmont is not like using your regular IV pump. With the Belmont, you will load the tubing without priming it and without attaching any fluids to it. Open the door to the unit. Snap the reservoir chamber into the holder. Fit the interlock block with the blue arrow on top of the shelf. The blue arrow should be on the top and pointing towards the machine. This will not click into place, but will be flush with the top of the machine. Thread the large light blue tubing along the wide blue line. Think blue on blue. Thread the clear tubing on the right along the thin blue line. Next, place the round heat exchanger into the center of the machine with the red arrow pointing up and run the red tubing along the red line. Think red on red. Place the pressure chamber into the pressure channel. Press the larger of the two tubings into the groove. You should press hard enough that it is flush with the air detectors, or even pushed in a little further. Then run it to the left of the black lever. Run the smaller tubing to the right of the air detector and down to the right of the black lever. Now, close and latch the door. Now it's time to turn on the Belmont. Once the tubing is secure and the door is shut, you will see the priming screen. The power switch is on the back of the machine. Remember to make sure that the machine is plugged into the wall and that the cord is attached snugly to the back of the machine. Make sure that the top 3 ports are clamped. Note, these are the only pieces that should be clamped. Everything else remains open. Attach your normal saline or blood product to the tubing and unclamp the line. You should not run lactated ringers on the Belmont. Products you can run on the Belmont are normal saline, packed red blood cells, and plasma. You can connect up to 3 bags of fluid to run at the same time. Each port can have its own bag. All fluids will run at the same rate if hung at the same level. This allows you to run blood, plasma, and normal saline at the same time. Lactated ringers should never be used on the Belmont. Remember, the fluids that can be run on the Belmont are normal saline, packed red blood cells, and plasma. The Belmont tubing has a blood filter on it. Fluids that should not be run on the Belmont include platelets, cryoprecipitate, lactated ringers, dextrose-containing fluids, or hypotonic fluids. After you have attached the fluid and unclamped the line, you are ready to prime. Press prime. The screen on the machine will indicate how much longer until this phase of priming is complete. It takes 100 milliliters to prime the tubing located inside the machine and takes around 13 seconds. The next screen will tell you that the system is now primed and that it is time to prime the patient line. Remember, you should already have your extension tubing attached to the Belmont. To prime the patient line, tap on Patient Line Prime. Tapping this once will have the machine prime the line at 50 mils per minute. If you want to prime faster, you can press and hold Patient Line Prime to run faster. Just like priming any other tubing, you will prime this line until you do not observe any air in the tubing from the machine to the end of the extension tubing. The end of the extension tubing has a cap with a hole in it to allow for priming without removing the cap. Press stop after you have confirmed that there is no air in the tubing. Check the tubing coming out of the machine all the way to the end of the tubing that will eventually be attached to the patient. You are now ready to connect the tubing to the patient and infuse. Our IV start kits come with the extension tubing attached to a blue clave. Do not attach the Belmont tubing to the extension tubing. This will drastically reduce the amount of flow. While the fluid will run through the blue clave, the rate will be diminished because of the blue clave. Do your best to attach the tubing directly to the hub of the IV catheter without a blue clave. This will allow for the fastest flow possible. After you have connected the tubing to the IV catheter in the patient, you are ready to infuse. Press Infuse. The infusion will start at 10 milliliters per minute. Let's look at the screen together. The top left boxes are the set rate and the actual rate. The set rate is how fast you have programmed the machine to run. The actual rate is how fast the fluid is actually going in. The actual rate is affected by the size of the catheter that is in the patient. The larger the IV, the faster the fluid will go into the patient. The middle right box shows you the amount of pressure it is taking to push the fluid in. The Belmont will never allow this pressure to be high enough to blow your IV. This lets you use the Belmont with any size of IV. Just remember, if you have a small IV, the fluid will go slower, and that's okay. You can adjust the set rate of the infusion by pressing the up and down arrows for the infuse rate. We suggest pressing the 500 mils per minute rate button to run your infusion as fast as possible. Remember, just because you set the rate at 500, you will likely not ever get that high. The volume infused is calculated for every drop of fluid that goes into the patient. This is located in the left middle box of the screen. You can also set the machine up for a specific bolus by pressing the bolus button on the right lower half of the screen. The volume infused of that bolus will be shown directly under the total amount of the bolus as it is being delivered and will be shown until the bolus is complete. You can choose to deliver 100 ml, 200 ml, 400 ml, 500 ml, or 1,000 milliliter bolus. To change the bolus amount, press the stop button on the bottom right. Then hold down the bolus button until the amount you would like to give is shown. Then release the button. The machine will automatically change the set rate to 200 milliliters per minute whenever you choose the bolus option. You can change that rate by either pressing the up and down arrows or by pressing the 500 milliliter per minute rate button. If you are running multiple products at the same time, they will all run together at the same rate. As we all know, things can get crazy during resuscitation, and you may not be paying attention to your fluids. You may be so happy about using that Belmont that you forget how fast the fluids are going in and be caught off guard when you run out of fluid. If you run your bag or bags dry, don't worry, this is one of our favorite things about the Belmont. The first thing you're going to want to do is press mute. This will make that loud sound the machine is making stop, and hopefully stop making everyone in the room look at you with the, "Why is that machine making that loud noise? And what did you do?" Press the mute button. Then replace whatever fluid you need to. Yep. Take away that empty bag and replace it with a new one. Once you do that, the screen will give you the option to reprime. This repriming only takes around 13 seconds, and then you're good to go. Hooray! As soon as the Belmont realized you were out of fluid, it clamped off the patient side of the tubing to ensure that no air would ever reach the patient. While the machine is repriming, the air is pushed up and out of the machine, and it never touches your patient. Once you have completed the resuscitation, you must turn off the machine to take the tubing out. If you don't turn off the machine, the tubing won't come out. Couple things to remember. The Belmont can run on a fully charged battery for about 30 minutes. When the Belmont is running on the battery, it can only run at 50 milliliters per minute, and it does not heat the fluid. If you notice that you can't get the Belmont to run more than 50 mils per minute, double check to make sure that it's plugged into the wall and the cord in the back is attached to the machine. If the machine won't turn on or turns off very quickly, make sure that it is plugged into the wall and that the cord in the back is attached to the machine. If you are working in the emergency department, we have blood products readily available. There are packed red blood cells and plasma in the trauma bay in the blood refrigerator. Remember, you can run packed red blood cells, plasma, and normal saline all at the same time if needed while using the Belmont. Tips for success. Make sure the Belmont is plugged in. Use the biggest IV you can. Connect the tubing directly to the hub of the IV catheter. Do not use blue claves. Do not infuse lactated ringers, platelets, or cryo when using the Belmont.
You notice how we spent a lot of time with making sure it's plugged into the back of the machine? The day we went to film this, we couldn't get the Belmont to turn on, and we called Biomed, and it wasn't plugged into the back of the machine. So we figured if we were struggling that much with it, we better make sure everybody else knew about it. The one thing I will say that probably isn't in here, that tip for success, and I will speak directly to trauma patients. If you have a trauma patient and we've decided to give blood or plasma through the Belmont, turn off the saline. We don't need it anymore. We would much rather have blood or plasma. Crystalloid is actually bad for trauma patients, and so we want to minimize its use as best as possible. Other thoughts on the Belmont? Questions? You all ready to go out and play with it? Okay. Another tip for success is if you have an IO in, it's probably only going to go 70, 80 mils per minute. That's it's faster than you can push it. It's warm, but don't call me and tell me it's broke, because when you tell me you have an IO, I'll go, well, that's about as fast as it's going to go. Remember, it will change your actual rate depending on the size of your IV. So, all right, thanks, guys.